Okay, thank you for the chance that given to me. And now our SGD will discuss about folic acid deficiency anemia. And this is our SGD. Okay, for the first one is anemia. Anemia is a condition where our red blood cell number is under normal condition. And it will lead into a mortality, and it is very dangerous. One of the etiology is folic acid deficiency. Folic acid is a water-soluble B vitamin, and in lower income country, the prevalence of folic acid deficiency is more than 20%. So this is why we need to study about folic acid deficiency anemia. And next will be discussed by my friend.
Okay, thank you for the opportunity. Now I'm going to talk about the problem statements, and I'm just going to mention of them. We are going to talk about folic acid deficiency anemia. So the things that we are going to talk about is the definition, epidemiology, etiology and risk factors, the pathogenesis, how to diagnose, what is the differential diagnosis, the management, complications, and the prognosis of folic acid deficiency anemia. The aims are supposed to answer those statements, and the benefits are the benefits is to provide the authors a further understanding about folic acid deficiency anemia. That's it from me. The next one is going to be explained by my colleague.
So now I'm going to explain about the definitions of folic acid deficiency anemia. Anemia is a condition where numbers of circulating red blood cells, or RBC, are lower than normal. And while folic acid is vitamin B that plays a big role in DNA synthesis of red blood cells. So anemia caused by folic acid deficiency is called folic acid deficiency anemia. Next.
Okay, the next is epidemiology. Anemia affect a third of world population and contribute to increased morbidity and mortality, decreased work productivity, and impaired neurological development. In 2010, anemia account for nearly 70 million years of life lived with disability. It is estimated that 75% of anemia is related to iron deficiency, followed by folate and vitamin B12 deficiency. Data on prevalence of vitamin B12 and folate deficiency at the national level are very limited. According to the National Health and Nutrition Examination Survey, data from 2003 and until 2006, the prevalence of folic acid deficiency in the United States has decreased from 16 to 0.5% since the dietary folic acid fortification program has started in the late 1990. In a study that found that the prevalence of folic acid deficiency was 2%, with the value of folic acid concentration is below 2 or 4 nanogram per deciliter. Another study report that folate deficiency anemia in women of reproductive ages in Pakistan is 60.8% using national level secondary survey data. One study from Indonesia reported that 53.9% of children and adolescents in rural area of Indonesia suffered from anemia, including folate and B12 deficiency. Next.
Next is about the etiology of folic acid deficiency, which may arise from a number of causes. First of all, including inadequate dietary folate ingestion. The human body can only store folate for as long as 4 months due to its hydrophilic feature. Hence, people need to regularly eat good food sources of folate, such as broccoli, asparagus, peas, and brown rice to prevent the development of folate deficiency. Moreover, cooking with extreme heat destroys folic acid. Aside from that, alcoholism is a significant cause of folate deficiency as well. Secondly, folate deficiency may develop due to impaired absorption, which are caused by diseases such as celiac disease, short bowel syndrome, gastric bypass, amyloidosis, or mesenteric vascular insufficiency, elevated pH, which may happen in acrohydria, and also by drugs such as methotrexate, phenytoin, sulfasalazine, and trimethoprim, as well as some anticonvulsants. Thirdly, folic acid deficiency can occur subsequent to vitamin B12 deficiency due to impairment of methionine synthase, resulting in the trapping of folate as methyl tetrahydrofolate, whereby methylene tetrahydrofolic acid accumulates in the serum, leading to folate trap phenomenon and increased urinary excretion of folate. Moreover, congenital deficiencies of enzymes, which are required in folate metabolism, can lead to folate deficiency as well. Eventually, there are some certain conditions where a person's body requires more folate than normal, so folate deficiency may develop when the body's demands are not met, such as in conditions like pregnancy, having cancer or blood disorders like hemolytic anemia, as well as suffering from infection or health condition that leads to an inflammation.
So this is the folate cycle. As we all can see, folate cycle needs folic acid. And here are the pathophysiology of folic acid deficiency anemia. Folic acid deficiency can lead to accumulation of DUTP and decreased thymidine, which affect DNA synthesis. And folic acid deficiency also causes prolongation of the S phase of cell cycle and maturation arrest. And this will result in megakaryocytes, which appear large with polylobated nuclei, detached lobes, and absent cytoplasmic granulation. Finally, megaloblastic anemia can occur. Thank you.
Next, clinical manifestations and laboratory examinations of folic acid deficiency anemia. So the physical examinations of folic acid deficiency anemia may reveal painful and also beefy red tongue, and some patients also complain about sore tongue and pain upon swallowing, and also may present gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and also diarrhea, especially after meals, and also signs of anorexia. And the neurological examinations may reveal cognitive impairment, depression, and dementia. And the clinical manifestations of folic acid deficiency may overlap with the clinical manifestations of vitamin B12 deficiency, and both of them can cause macrocytic anemia. And the laboratory examinations should include CBC and peripheral blood smear, and the result may show decrease in hemoglobin and also hematocrit levels, and the MCV higher than 100. And the peripheral blood smear will show macrocytic red blood cells and also hypersegmented neutrophils. And the folic acid deficiency anemia will diagnose if the HB under 12 grams per deciliter for women and HB under 13 grams per deciliter, and also serum folic acid under 2.6 nanograms per milliliter for men. And the folic acid deficiency anemia shows normal B12, normal MME level, and elevated homocysteine levels. And bone marrow evaluations may show hypercellularity with megaloblastic erythroid hyperplasia of cells.
My name is SGD and I'll explain about the differential diagnosis of folic acid anemia. First, there are vitamin B12 deficiency. Vitamin B12 deficiency may lead to a reduction in healthy red blood cell. It could also affect the nervous system. Some of the symptoms include fatigue, numbness, and memory trouble. The second is alcohol liver disease. Alcohol liver disease is caused by continued excessive consumption of alcohol over a long period of time. Some of the symptoms related to this disease is jaundice, swelling in abdomen, enlarged breast, bleeding gums, and weight loss. The third is hypothyroidism. Hypothyroidism is a condition where thyroid gland doesn't produce enough thyroid hormone. Some related symptoms include fatigue, cold sensitivity, unexplained weight gain, and constipation. The last is aplastic anemia. Aplastic anemia is a rare disease that caused by marrow failure, and that involves a more primitive progenitor of multipotent stem cells. Usually it is associated with anemia that has a variable disease of white blood cell and platelet. Thank you.
The first line of folic acid deficiency anemia treatment is folic acid supplement. It is given every day orally with 1 to 5 milligram per day for increasing the folic acid concentration back into normal. Sometimes subcutaneous, intravenous, or intramuscular is used to treat people who are actually unable to consume the folic acid orally. The duration of the therapy depends on the persistence of the causal of folic acid deficiency, with the average duration of treatment is 2 to 4 months. Patients with malabsorption usually needs longer treatment. After the folic acid concentration back to normal, the patient needs to change their diet habit. Patients have to consume food and meal with high or rich folic acid, such as fortified breads, cereals, citrus fruits, and green vegetables such as broccoli, Brussels sprouts, and peas.
Hello, my name is Lars and my number is 103, so I will explain about complication. So the complication of folic deficiency anemia in pregnancy could happen during pregnancy and cause neural tube defect. So what is neural tube defect? Neural tube defect is a serious condition which occurs to the baby and can cause death before or soon after birth. This condition happens when the neural tube, which from the early spinal cord and the brain, does not close properly, so it could not develop normally. The most common neural tube defects are anencephaly or a brain defect and a spina bifida, a spinal cord defect. Also, it may cause paralysis of the legs. And neural tube defects usually happen in the first week of pregnancy. And the next one will explain by my friend.
Hi, my name is Duko Pratno and I will explain about prevention of folic acid deficiency anemia. For prevention of folic acid deficiency anemia, it is important to educate patients about healthy diet considering it is one of the risk factors of folic acid deficiency anemia. Patients should be encouraged to take healthy diet with adequate intake of green leafy vegetables like spinach and fruit. And if it's considered important, supplementation at dose 1 mg daily can be used to prevent folic acid deficiency, which can lead to folic acid deficiency anemia. When planning pregnancies, it is recommended to take folate prevents neural tube defects pre-gestational supplementations, daily supplemental of folate with dose of 400 micrograms each day, parenteral nutrition with high folic acid content in preterm infants, make it no risk of folate deficiency during 2 months of age.
So for the prognosis, proper treatment will result in good prognosis and generally will treat most clinical and biochemical abnormalities seen with folic acid deficiency. However, without the proper treatment, lack of folic acid can lead into macrocytic anemia, and it also raises levels of homocysteine that is associated with atherosclerotic disease. For the pregnancy-related complications, for example, placenta abruptia, spontaneous abortion, neural tube defect, severe language deficits in the offspring, can also be caused by the lack of folate.
So here I want to conclude our presentation. So folic acid deficiency anemia is a type of anemia caused by folic acid deficiency. Lack of folic acid causes a decrease in conversion of DHTP to thymidine, which affect DNA synthesis. The physical examination that might appear are painful and beefy red tongue, pain upon swallowing, and gastrointestinal symptoms. Initial laboratory tests that were needed are CBC and peripheral blood smear. For prevention, it is important to educate our patient about healthy diet with adequate intake of green leafy vegetables like spinach and fruits. The first line treatment are folic acid supplement every day, typically oral 1 to 5 mg per day. Proper treatment will result in a good prognosis. So that's all about our presentation. Thank you for your attention and have a good day.